Hi, Dr. Anna. It's great to see you again.
Hello, Trish. Great to see you again, too. And please call me John.
Of course. Thanks, John. I know we only have 10 minutes today, and we usually get a half hour. And falls prevention is a big topic. So I want to put it to you to sort of say, hey, what's your biggest challenge with preventing falls in your practice?
Well, I'll give you an example. I have a patient who has knee osteoarthritis, and a couple of months ago, I found out that she fell. And when I learned about this, I frankly felt terrible. I thought I should have been able to prevent this. So I would love it if you could help me with this. Like, how can I do that? How can I be more proactive in my clinic for preventing falls?
Yes, I can help you with that. And it's a terrible feeling, I know, when you feel you could have done something more to prevent. So I'm going to suggest a few simple, high-yield things you can do in your clinic to sort of help with falls prevention. The first is to screen everybody age 65 and over by asking if they've had a fall in the past year. You can also do a quick check of issues with their gait, their mobility, and their balance. And if you notice any issues there, that identifies a falls risk. How are you doing that in your practice right now?
It's really a holistic thing. When I see them, I examine their gait when they're walking toward my clinic room. I look at how they're sitting down in the chair and getting up from the chair, how they're transferring, if I'm doing a physical exam, how they're transferring to the exam table. It's more of a kind of informal thing. Would you recommend anything more formal?
Well, that's a fantastic and very efficient way to get a look at the gait. If you're looking for something more formal, some folks will do what's called a timed up and go test or a tug test, where they have the patient seated in a chair. They rise from the chair, they walk 3 meters or 10 feet. They go back to the chair and sit down, and that's timed and observed. And if it takes more than 12 seconds, that indicates a higher fall risk. So that's something that folks do. But observing the gait is a great way too. And then just coupling that with the screening question of, have you fallen in the past year, or have you changed your activities to avoid a fall? And what that does, a lot of patients they don't think to mention it to their doctor, or they're afraid to mention it because they're worried about losing their independence. So it's definitely something that's worth asking. It's something that you can also put into your EMR to screen everyone over 65.
Yeah, anything to automatize things that would be great. Yeah, thank you.
Exactly. Yeah, and I can help you set that up when we have some more time. So that's a great place to start with the screening. When you do identify that person, the quickest thing to start with, because you don't have to address all those falls risk factors at once, is to offer some handouts. And there's some great ones, for example, from Osteoporosis Canada on physical activity. There's a good one on nutrition. There's a home safety checklist as well as a safe shoe checklist. And we also have identified a really good one on postural hypotension. And those are all a great way to get started on reducing some of those risk factors.
Great. Yeah, I love handouts. They extend the education of the session, but also I find that, patients just often don't remember what I recommended in the previous visit. So that would be really helpful. And it's also good for, my patients that are, not very internet savvy, or even those who have language barriers, because sometimes our clinic can have a handout or two translated.
Fantastic. Yeah, and another really high value intervention is to do a referral to CCAC, or home and community care, to do the home safety check and the mobility devices. Is that something you're doing in your practice?
Yeah, for sure. Yeah, I use the LIN. Yeah.
Fantastic. Okay, so then after that, we start getting into a more targeted intervention for the patient's individual risk factors. I'm going to share something on my screen right now, just showing some of the more common risk factors. And I want to get your sense, because I know we are very short on time today. Are you able to see my screen okay here? Just going to pop over here. Sorry about that. Is there one risk factor that stands out for you?
Certainly medications. I was just seeing a patient the other day. She has poor mobility, uses a rollator walker, and is slow with the rollator walker. She has multiple comorbidities, including chronic pain, and is on medications. In fact, her medication list is as long as my arm. So, I think here's a patient with a lot of risk factors for falls. And I'd like to address medications, but each of those meds I feel was prescribed for a good reason. So, I don't really know where to start. And as well, my patients are often coming for other reasons, right? So it's hard to kind of fit all of that in one appointment. How would you recommend I start?
Yeah, so you've already got a lot going on in that visit. It's not as simple as you say as just deprescribing all the falls risk meds, as they were prescribed for a reason. So I think sometimes the easiest way to get started is to refer that patient for a med review from a pharmacist or from a service called Jerry MedRisk. Have you heard of them?
I've been on their website, but I don't know much about them. Can you tell me a bit?
Yeah, sure. So they're a not-for-profit group that does a geriatric consults for complex patients or patients on a lot of medications, and they can help with deprescribing. I know there's a lot on this slide, but you can check out their website. I can send that to you, and you can take a look. They're a nice option for when you're waiting for resources in your local area to refer to. So yeah, it's an option to check out.
Sounds good. Will do.
Okay, fantastic. And then just going back to sort of how to approach these patients on a lot of medications. And a good screen is, are they on 3 or 4 medications or more? And that's a good sign for referring for a med review. These are the most common falls risk medications. Any surprises there on that list?
Yeah, PPIs jumps out at me. That surprises me. Why are PPIs a falls risk?
Yeah, so that surprised a lot of people for sure. And it's related to absorption. As you know, they reduce the gastric acidity, and because of that, there's less absorption of calcium, and that leads to a reduced bone mineral density, increased fracture risk, as well as a reduced absorption of vitamin B12, which can lead to a peripheral neuropathy, which can make the falls risk higher. So,
okay, makes sense.
Yeah. Tends to happen once you've been on them for a year or more. But yeah, so I know in previous visits, we've talked a bit about the opioids, the hypoglycemics, as well as the benzodiazepines, and we can do a follow-up at any point to talk more about deprescribing there in more detail, including that patient. I wanted to see how it went with the most recent one we talked about with the benzodiazepines.
Yeah, I actually, you sent me an infographic that was really helpful that showed like a tapering schedule, and I've used that with one of my patients. That was enormously helpful.
Fantastic. Was it this one here?
Yep, the one on the
Excellent.
right. Yep.
Yeah, that's great. And it's one of those ones that's actually been studied and shown that patients who receive this in the mail can deprescribe themselves about 30% of the time. So it's a nice resource to have for sure.
Great. Any more things you have like that, please send them over. That would be great.
Yes, we actually happen to have that for, it's not our group who does it, but the Deprescribing Network, and they have them for opioids, for sulfonylureas, for PPIs, and also for antipsychotics. So I'd be happy to send that. And I know we've only got a couple minutes left. I wanted to check in with you to see if there's anything else you're really hoping we could cover.
The only thing is, as you know, my patient population, many refugees, many low-income patients, and I often struggle to think about how to connect them with mobility aids that are free or low cost. And so, any advice about that you could provide would be great.
Sure, I've done some research into the resources in your neighborhood, and I can send you a list of some low and no cost options.
That would be amazing. And by the way, thanks for sending me that link to your COVID resource center, their COVID resource page, because I found it really helpful. Your section on Indigenous patients and vaccination, and also the new antivirals and sorting all of that out. That was great.
Sure, I'm so glad it was helpful. And I know we're almost at our 10 minutes and you need to get going. I want to respect your time. So what I'll do is we'll say bye, and I'll email you all the resources we discussed, as well as the mobility device info, and happy to set up a follow-up, as I know we didn't get our usual half hour.
Amazing. That would be great. Well, I look forward to next time.
Okay, thanks for your time, John. It's great to see you.
Likewise. Always a pleasure. Thanks so much.
All right, see you next time.
See you.